I had a newly diagnosed bladder cancer patient ask me a question yesterday, and it got me to thinking maybe I should explain a little bit on how I came up with what I did as far as my decision with BCG therapy for my bladder cancer, non-muscle invasive bladder cancer. But before we begin, make sure you go to beacon.org, BCAN.org, Bladder Cancer Advocacy Network. If you have any questions about being diagnosed with bladder cancer or a caregiver possibly, or ways that you can donate, they have a ton of resources and a ton of help, something that I should have used more when I was diagnosed more than a year ago. But a fellow bladder cancer patient asked me yesterday about BCG therapy as it pertained to their bladder cancer, and we had a similar cancer, so I thought that I could answer him correctly on it. So I went ahead and embellished. Let me go ahead and read what was written here. I was recently diagnosed with bladder cancer at 41. I was occasionally peeing blood and having issues urinating, and a CT scan showed a tumor in my bladder. Within 3 weeks, I had turbot, had local chemo placed in the bladder once during turbot. Tumor was 3 centimeters. Biopsy showed low-grade NMIBC. My doctor said additional chemo or BCG wasn't necessary, and I have a cysto schedule for late February. Was curious why your doc recommended BCG when your cancer was low grade and non-muscle invasive. I'm worried my doc isn't being proactive enough, which is very normal. That was one problem that I had. I didn't really have a problem. My doctor, he seemed like he was always being proactive enough and always put an urgency behind what he did and explained everything. But I won't get into how I answered this person. But I definitely directed them to how I came up with my decision about BCG therapy, which was just on an internet search. I found the scientific study. So just go to Google and put in bladder cancer scientific study, BCG, somewhere along that route, and it will come up. It's the National Library of Medicine. It's an actual scientific study, or at least one rendering of it, for BCG therapy, and exactly answered my question when it came to whether or not I should get it. So I will put the link in the description. It is all a bunch of scientific jargon. Keep that in mind. But we're going to go ahead and hit certain points of it where we're going to draw some layman information from it. Keep in mind always, get with your doctor. Go with your doctor's idea and plan. They are the professionals. They are the people who come up with this. My doctor has a proven track record, and it aligns with my research. Enough for a layman, you know what I mean? But do your research. Get your information from everywhere. Do not be afraid to switch doctors. I know that's a big step, and I didn't have to. But if you're not happy, you're not happy. You have to be an advocate for yourself. You have to. You might have caregivers and people that love you, but you have to stand up for yourself when it comes to this stuff. So, yes, this person was nice enough to ask me this question, and I went ahead and answered them on what I thought, which is kind of lengthy, and that's why I thought I'd explain it. So, the National Library of Medicine, the simple summary right at the beginning, BCG, a liver attenuated strain of Mycobacterium bovis, is the most successful microbial immunotherapy of cancer in current use. Intravesical treatment with BCG is recommended for most patients with high-risk non-muscle invasive bladder cancer, or NMIBC. This is very important. It puts us into the correct category for this study. In patients with NMIBC, non-muscle invasive bladder cancer, treatment with BCG is associated with reduced risk of bladder cancer recurrence and progression compared to transurethral resection alone. That's the actual surgery, the turbot. Here we summarize the current data regarding mechanism of BCG and review indications of recommended practice for BCG treatment of bladder cancer. So, very important. Most patients with high-risk non-muscle invasive bladder cancer. Now, I have low to moderate risk non-muscle invasive bladder cancer, which I've talked to my doctor, and that puts me into the category of this study. It's not only for high risk due to what my doctor says. So, in reference to the question from the Reddit user, maybe their experience and their professional experience says on something that's not high risk or low grade that they don't have to worry about BCG therapy. This is very much a possibility. Keep that in mind. Talk to your doctor. Ask them about that. But the last time I talked to my doctor, I said something about low grade, and he said, wait, you're low to intermediate grade. So maybe that put him, he was more apt to put me into this type of therapy. So there's a long and short of it. Non-muscle invasive bladder cancer, because also the question was on Reddit too, as opposed to muscle invasive bladder cancer. So muscle invasive bladder cancer puts you into a totally different category. I don't believe, you would have to do your research on this because I have not, that BCG is necessarily a route that you can go on muscle invasive bladder cancer. So I wouldn't worry about that particular category. That's like a whole different category, of which we did not, me and this person did not have muscle invasive. So that rest of that metastatic cancer that's really bad, when you get high risk or muscle invasive bladder cancer, in what I've just glanced at through my research, is they're looking to take your bladder almost right away because it's so infectious by the time you get to muscle invasive. I will always feel lucky for being non-muscle invasive bladder cancer. So that puts us into a certain category. So maybe if you are super low grade, maybe it's a red flag to my doctor that I'm intermediate grade, and maybe that's why you do not need BCG therapy. Now, this person did mention too that they had gemcitabine, additional chemo or BCG, but they had local chemo placed in bladder during turbot. That is what I had too. I had it during turbot, and I actually had it again when I had my stent removed. And I did read somewhere, and you would have to find this yourself, that immediate application of gemcitabine, which is chemotherapy, reduces the risk of it coming back like immediately to some degree. But do your own research on that. So, all right, that puts us into the right category for BCG therapy. Okay. So then, as far as clinical efficacy goes, now, I'm a layman. I'm not a doctor. I just know how to pronounce efficacy really well. But there's a lot of logic in this stuff. The stuff that I skipped over, everybody, read it. I've read this whole thing on several different occasions, and I'm not a doctor, and I'm not a research scientist, so I don't know a good amount of it. But I did go to college, and I do know how to read scientific studies to a certain degree. But go ahead and read through them. So when we go to the clinical efficacy, recurrence-free survival is exactly what it means. Recurrence-free survival. That's our rate. That's when we're going to get our turbot, we're going to get our BCG, and then we're going to get checked over time and whether our tumors come back. So current management of NMIBC, non-muscle invasive bladder cancer, involves initial complete resection accomplished via transurethral resection of a bladder tumor, turbot, which I keep saying, that's the surgery. That's taking out my grape-sized tumor that I had. With post-operative surveillance by cystoscopy, which I also have. I get them a couple times a year. They're not very pleasant, but they are necessary to see if tumors come back. And so far with me, no tumors back. Without adjunctive post-resection therapy, which is after turbot BCG, The cancer recurrence is in 50 to 70% of patients with non-muscle invasive bladder cancer, especially those with high-risk tumors, even with the complete resection of the tumor. So let's go back on that. Without the BCG therapy, the recurrence, so if I went and I had it pulled out, if I didn't get the tumor out in the first place, it would have gotten worse, obviously. If I get it pulled out and I don't get post-resection therapy, post-surgery therapy, it returns in 50 to 70%, which is terrible odds. Might as well put myself up to 70% when I say that. That only 30% of people don't get return tumors when they do that alone. So that sold me kind of right off the bat. But even still, I didn't have a high-risk tumor, which threw me into a little bit different category. It's fine. This works as most effective on those with high-risk tumors, so I wouldn't know what the odds are on that. You have to look into that if you have a high-risk tumor. And they once again, and they do it quite a bit, claim that it's the most effective therapy in reducing the risk of recurrence in patients with intermediate and high risk and NMIBC. So there it is, intermediate. That's where my doctor put me, and that might be why I'm in it. So once again, Reddit user, you might not need it. The gemcitabine during turbot was possibly enough, but look into that. An early study demonstrated that a 5-year recurrence-free survival rate of 80% in those treated with intravesical BCG in combination with percutaneous vaccination. I asked my doctor about percutaneous vaccination. I think that's a tuberculosis vaccination, so we're actually going to skip that. But 80% in 5 years were still alive, compared to 48 who did not receive BCG. So once again, there's an obviousness there that it's proven, and I would have to take a chance with that when I first read this before my BCG. And every time my doctor, he even just said with my last cystoscopy, he said, we'll come and we'll do another one, and then we'll discuss whether you want to get BCG again. And I'm always like, let's go. And he doesn't argue with me. So maybe he will next time. I don't know. 80% 5-year survival. Thank you very much. That's awesome. I'm going for that. Always a 48% not survival. So that obviously means that it returns. And I hope I find it here, but I believe I've read at least in more than one place when it does return as high-risk muscle invasive, or not muscle invasive necessarily, but it returns as high risk. So when you got high risk, it's not good. They want to take your bladder at that point sometimes. A lot of the jargon here, 6 weekly doses, and we start to get into doses. Adjunct intravesical BCG therapy confirmed. Very good. Due to recurrence, this is just a recap of due to just, the recurrence. Due to turbot alone, the recurrence rate is much higher. If you go through BCG, it just takes care of it. And from what I understand too, if you couldn't see one with the naked eye with the cystoscopy, that when you have the BCG therapy, it infiltrates the cancer cells that you cannot see. So it gets rid of them before they ever get a chance to grow. So the next thing that I was brought to when I was researching this terrible disease was the actual studies themselves. Now, bear with me. Once again, I am a layman. And this is really the bread and butter of like what happened. You can get an idea for what the scientists were doing. So very, very, on our headings here, I'll kind of go back and I'll kind of recap. We'll go through this like I was going through this. Okay, in 1985, this research scientist Lamb, 60 patients, N is the number of patients, 120 milligrams intravesical Pasteur plus 5 milligrams percutaneous. Now, you'd have to look all that up, but intravesical obviously means up the urethra. Which is how I get it now. This is 1985. Like I said, weekly, once a week for 6 weeks. So the recurrence rate, 3 out of 6 with BCG and 4 out of 6 without BCG. So they did better. Not like great better, but half didn't get it, and one more got it when they didn't do BCG. And this recurrence relative risk, I think that's like a statistical deviation or something, 0.75. So we're actually going to ignore that because I don't know what that is. So then in 1985, once Lamb was done, presumably, Pinsky in 1985, 120 milligrams intravesical Armand Frappier times 5 percutaneous. So what I notice here is they do the same dose, but there's a different type of BCG. Okay, so 27 out of 41. It looks like about half, a little more than half, that had the BCG. No BCG. It's still, that's about the same. So that really looks like a bit of a not a failed study, possibly, or at least the same as the one before. So Yamamoto in 1990, 44 people, 80 milligrams Tokyo. This looks like a different type. So the administration weekly, 6 weeks, and then every 2 weeks times 12 weeks every month. So what they're doing here in a nutshell is they're doing that induction, that first 6 weeks, which is what I got. And then they're doing the maintenance, which the maintenance is very important. We'll see in a little bit when it comes to recurrence rate. So then on these, let's say, 4 out of 20 BCG, 13 out of 20 with none. So here the odds are starting to look a little bit better. 20 people, only 4 got it back. And with no BCG out of 2013. So there's an obviousness there once again about how having BCG compares with tumor growth after surgery while using it. So whatever this 80 milligrams, it could have been the dose. It could have, because these ones were 120. Could have been the type. Probably the type. 1991, another year goes by. Pagano, 189 patients, so quite a bit more. 75 milligrams intravesical Pasteur. So he actually goes back and he changes the dosage, because it was 120 milligrams intravesical Pasteur here, but he laid off the 5 milligrams percutaneous. Percutaneous means in the skin, like an injection in the skin. So you would have to look up what that was if you were interested. It's not really important to what we're studying here. Pagano, 91, 189 patients, 75 milligrams intravesical Pasteur, weekly 6, initial dose, which seems to be proven, and then a different type of maintenance. Monthly times a year, quarterly times a year. So 6 recurrent out of 43. See, on this last one we have 4 out of 20. 6 out of 43 recurrent. That's actually good. That's really good. And you can see these numbers keep going down. So obviously these standard deviations, whatever they are, when they go down, we're looking better. Okay. So Melekos, 1990, we're going back in time. Which would make sense. They're doing it by order of importance, probably. 100 patients, 150 milligrams versus 75 intravesical Pasteur. So shows me that he had some success here. So Melekos might have been trying to embellish on his success. So weekly, initial 6, which they always go for. And then maintenance doses every 3 months times 2 years. That's quite a bit. Now I'm on 3 years total. So they're upping that maintenance time. 11 out of 67 with BCG, 14 out of 33 no. So without even looking at those numbers and trying to quantify them in our minds, 0.38 shoots us back up because we're 0.31. We went to 0.18, it's looking good, back up. So we're going to scrap that one, right? So it looks like this one went back up too. So in 1996, Kriege, 337 patients, 120 milligrams of Connaught. So it looks like maybe a new type. The initial dose, 6 weeks, and monthly for 4 months. So I don't know how much monthly for 4 months, maybe like once a month. So 0.78, we're headed back up. Not working very good. 28 out of 98. All right, but not bad. Not bad odds. So then, from what I noticed, was this stuff kind of totally changed. I took out this standard deviation, and we talk about percentage of recurrence rate. And this was right when TICE came on. Now, TICE is what I get. That's the name of the BCG medication that I get. So we come up here to AIR in 2011, which quite a bit of time went by. So presumably, people were treated and saved all through this, because the recurrence rate were looking good, and they kept embellishing on their studies. So then the TICE comes out in 2011, and hair in 816 patients, and the patients are going up. 50 milligrams of TICE, weekly, times 6, always been the same, so they really established that weekly introduction dose, and no maintenance. So 27% recurrence. Okay, not bad odds. That puts us in the 73 to 75, 73% category of clear scans. 73% survival. All these things kind of correlate. Definitely, let's not say survival, but let's say recurrence of tumors, because that's what we want. We had low grade. We do not want high grade. So this is what we want. So next, I cannot pronounce, Facanios. 2014, so a few years go by before another one, 1021, and they try 50 milligrams of TICE again, obviously to correlate these two, and they did, 28%, 27 and 28%. So then Matele in 2021, which isn't too long ago, 50 milligrams of TICE, and then the only change was weekly, greater than or equal to 5, which I got 6 on that starter dose. So they further refine that. Greater than or less or equal to 5 on the induction, which is our first 6. And then greater than or equal to 2 maintenance. Now this actually was what, there might actually be more. I'm not even really sure. The only thing I can go on in this is my schedule. I got the induction by 6, and then for 3 years, and I think that's what they mean, greater than or equal to 2 years maintenance. So I'm going to get a greater, it's 2 to 3 maintenance. So 542 patients, fill it 50 milligrams of TICE, 8%. So that actually puts our tumor recurrence, successful turbot surgery, not muscle invasive bladder cancer, 8% recurrence. So we have a 92% chance of not having a future tumor. So that is, by the time I was done with that, absolutely no question whatsoever, if I fall into the category, I'm doing it. Health and medicine combined. Get your butt to the gym, eat right, fix all the stuff you let go out the lines, and then you'll be fine. So there is our actual study. Sorry it's so complicated, but this is what I went through. I mean, this poor person who asked me this and read it, I want to give them this link because you're scared. You know what's going to happen. Yes, it is a terrible cancer. Yes, you have to. Prevention is the key once you know you have it with this cancer. So there was on the safety I wanted to hit a little bit too. As compared to intravesical chemotherapy, which I had 2 of those, one after my turbot, one after my stent removal. BCG is more commonly associated with side effects. So I think with the gemcitabine chemotherapy, I did feel quite an irritation on that. I did not like that. But I do feel it on BCG too. Nevertheless, serious side effects are rare and usually treatable. Most common side effects of BCG are irritative urinary symptoms such as dysuria, urinary frequency, and urinary urgency. I concur with that. That's what you get. Such symptoms are usually transient. Patients in whom such symptoms persist should be evaluated for presence of bacterial cystitis and if confirmed treated with antibiotics. So there is a possibility you could get a infection. I did ask my doctor when I first started going through this. He said one person they thought had something, but it was just an infection. It wasn't like a tuberculosis infection. So skin rash, systemic toxicities such as fever, malaise, and skin rash. I did have that. I was tired, skin rash, just for the first little bit. I've got another video out there where I actually talk about some of the side effects, and I have a few videos where I do before and after, so check those out on TikTok. 39% of patients can feel it, fewer than 10%. Require people to stop in 10% of cases, so it could in fact be bad, and you might not be able to stand it. I have been going through it for a year, and I'm fine. Let's see. Hepatitis, this stuff, you be careful. Think about your risks. Think about being healthy. That's about all I got. Once again, go to Bladder Cancer Advocacy Network for all of your information. You can even be linked up with another bladder cancer patient that has some experience in your type that you can email, talk to on the phone. I'm actually one of those volunteers for Beacon. And there's a walk in a bunch of different cities and ways to donate. This year is a big year for therapies, 2025, so possibly give some money to that. And this is just a great resource page. And thank you so much to the Reddit user that asked me that question and gave me some material to embellish on. So BCG therapy, guys, if you have non-muscle invasive bladder cancer, intermediate to high-risk bladder cancer, in my opinion, it's a no-brainer.